Well, I guess should I introduce myself, or I don't know how I should start. Okay, I'm Robin Cody. I am one of the instructors here at Keiser University. And today I'm going to do a little overview on pediatric nutrition. First, we're going to just start with some general information, talk about the growth charts and energy, protein, fluid needs. And then we're going to get into infant nutrition, then low birth weight or premature infant nutrition, because they have a lot of special nutrition considerations for that group. And then a little bit about childhood and adolescent nutrition. And then at the end, really briefly, I'm just going to touch on all of the common disease states and disorders with pediatrics, just some of the more common ones, and some of the nutrition implications with each of those. So, okay, so with pediatrics, we know that it's very, very different with infants and children than it is for adults, because we have to factor in the fact that they're growing and developing and they need to be gaining weight. And with adults, when we're doing their assessment, a lot of times we're trying to get them to lose weight, right? And possibly just maintain weight, but usually not gain weight. But with infants and children, that's the big thing, is they're supposed to be gaining weight. And if they're not, that's a problem. So we need to be plotting them on the growth chart and making sure they're following that correct curve and gaining weight. Physical growth does occur at different rates. As the infant becomes adults, they go through growth spurts or whatnot. And we can measure growth a couple of different ways. One is by average daily weight gain. So you can actually, let's say you're following an infant in the hospital, get their weight on Monday when they're admitted, and then the following Monday get their weight, and they should have gained a certain amount each day for those 7 days. And there's charts I'll show you as to what that weight is supposed to be. And then also we know we can plot them on the growth chart. So you know the growth charts, the males and females. There's the 0 to 36 month growth charts, which we plot weight for age, length for age, weight for length, and head circumference for age, and then the growth charts for 2 to 18 years for children and adolescents. So, and that's your weight for age, height for age, and BMI for age. And BMI we don't do for the 0 to 36 months because we're plotting weight for length. So we're just going to do BMI only for the 2 to 18-year-olds. You calculate BMI the same way as you would for adults, but we don't use that scale for overweight and obesity like we do for adults. So with children, you calculate the BMI and then you plot it, and then you assess it, okay? So their BMI isn't always going to mean the same thing as an adult's would, so you have to plot it. And I just threw in the growth charts here so you could see the CDC growth charts. The pink ones are always females, the blues males. So make sure you have the right ones because they are different. Here's the 0 to 36 months. So you have weight for age here, and then length for age up here. That's the front, and then the back of the growth chart is your weight for length and then your head circumference. And we do plot head circumference for the 0 to 36 months because it does tell us about their nutrition. So if their head circumference is plotting small, it can mean that they're not growing properly. It can mean the brain's not developing. And if it's plotting large, it can mean that they have fluid in their brain. So it's an important thing to plot. And their brain grows the most during the first 3 years. So that's why we look at it for 0 to 36 months, but we don't look at it after about 3 years. So just for the 0 to 36 months, for boys and girls, we do the head circumference. Another important thing to remember with the growth charts, let's say for instance, this is a male, you have a 9-month-old male, and let's say he's plotting, I don't know, I guess let's say somewhere around like 9.8 kilograms, okay? So he's gonna be between the 50th and 75th percentile. So you're not gonna say, oh, it looks like he's around the 62nd percentile. You're never gonna do that because you can never get that exactly right. So you're always going to, in your assessment, just state that he's in between the 50th and 75th percentile, okay? So that's how you use the growth charts. And then here's the girls 2 to 20 and the boys 2 to 20 years. So the difference is that on the back of the growth chart, you're just plotting BMI for age. You're not doing the head circumference anymore. So on the front, you have your weight for age, your height for age, and then on the back, you have your BMI, okay? Okay, this slide shows the recommended dietary allowances for energy and protein, and these are by the National Research Council from the National Academy of Sciences. So this is a nice little chart to have, and it gives you calories per kilogram per day of protein, grams per kilogram per day. So for infants and children, just based on their years. And as you can see, the energy, the numbers in red, they're a lot different than for adults. With adults, calories per kilogram, we think 25, 30, maybe 35 if they need extra. But with infants, 108 calories per kilogram for 0 to 6 months. So a lot higher calorie and protein per kilogram than for adults. And then it starts going down as they get older. So for instance, 1 to 3 is 102 calories per kilogram. So that's a chart that gives you calories per kilogram and grams of protein per kilogram per day. And then I have a couple slides here with some equations to calculate resting energy expenditure for infants and children. So this is from the World Health Organization. So it's broken down into years and then males and females, and you just plug in their weight in kilograms into those calculations. So that's another way. And then here's the Schofield equation. So this is another way to calculate the resting energy expenditure for infants and children. So again, their age, and then you have to plug in weight in kilograms and then also height in meters for this one. Okay, so there's a couple different methods, but keep in mind with the last two methods, the Schofield and the WHO equations, you do have to multiply those by a stress factor because those are resting energy expenditures. So you do need to take into account any type of illness or starvation or anything that's going on, and that has to be multiplied by a stress factor. So with starvation, we know the body's adapted and the metabolic rate's actually lowered. So we actually are going to give them less calories. So you're going to multiply by 0.7 to 0.85. But with the rest of these are different types of stress, surgery, sepsis, closed head injury, trauma, growth failure, burns, all of those, we're going to give them more calories. So make sure you multiply by that stress factor for those infants or children. So they're going to require more calories. For fluid needs, we usually use the Holiday-Seeger method for calculating fluid requirements. So just based on their weight in kilograms, not pounds, kilograms. So for 0 to 10 kilograms, they're going to get 100 milliliters per kilogram. So again, very different than with adults, right? Adults is more like 30, 35 milliliters per kilogram. This is 3 times as much, so very different. 10 to 20 kilograms, you're going to take 1,000 milliliters and then add 50 milliliters per kilogram for every kilogram they are over 10 kilograms. And then if they're greater than 20 kilograms, you start with 1,500 milliliters and add 20 milliliters per kilogram for every kilogram over 20 kilograms that they are, okay? So very different as far as calculating fluid requirements. Okay, fiber, the DRI for fiber for infants and children is 14 grams per every 1,000 calories that they need. So you'd calculate their calorie needs, and then you'd be able to determine for every 1,000 calories that they need about 14 grams of fiber. Then there's also a table there that pretty much corresponds to that calculation. So those are the DRIs for fiber for the different ages. Okay, so now I'm going to kind of move into some specifics for just infants. So infants, basically the definition is this is the first 2 years of life, okay? Infants lose about 6% of their body weight during those first few days of life, and then they'll regain it by about the 7th to 10th day. So it's very normal to see weight loss, to see on that growth chart their weight's going to actually decline in that first few days. Their birth weight should double by about 4 to 6 months and triple by about 1 year. So that's a good rule of thumb. The amount of weight that they gain during their second year of life should be approximately equal to whatever their birth weight was. So if they were 7 pounds at birth, they should gain about 7 pounds during that second year of life. Their length is increased by 50% during the first year, and then it's doubled by 4 years. So if their birth length is 18 inches, it should be 36 inches at 4 years. They should be about 3 feet, so it should double. Their total body fat is increased rapidly during that very first 9 months. Then it starts to kind of taper off through childhood, and then it's going to bounce back up when they hit puberty. Their total body water decreases through infancy from starting at about 70% at birth to going down to about 60% at 1 year. And you know, with adults, females are about 50% total body water, males about 60%, so it's going to go down maybe a little bit more. The stomach capacity for infants is only maybe 10 to 20 milliliters when they're born, so that's not even an ounce if you think about it. 30 mLs is an ounce. And then it's going to increase to about 200 mLs by about 1 year, so that's roughly 6 to 7 ounces. Their kidneys at birth are still immature, and they're going to increase in size and their concentrating ability as they get older. So it's really important to make sure they're getting properly prepared formula and it's not too concentrated, because their kidneys are not going to be able to concentrate it and excrete it as urine. Okay, energy needs for infants. Full-term infants that are fed your standard formula or breast milk, they usually can adjust their intake, so they're gonna let us know when they're hungry, and they're gonna stop eating when they're full. So typically, full-term infants can kind of meet their energy needs on their own with standard formula. But we want to, of course, monitor their length, their weight, their head circumference, and their weight for length, and just make sure they're following that growth curve like they should be. With protein, the requirements for infants are higher per kilogram than for adults or children. And that's just because they're forming that lean body mass, they're forming tissue, and just in general, their needs for growth are just higher. The current recommendation is to consume a minimum of 30 grams of fat per day for infants that are less than a year. Breast milk and formula provide that amount, so they're sufficient. And then carbohydrates should provide about 30 to 60% of their total energy during infancy. Breast milk provides 40%, formula 40 to 50%, so they both fall within that range for total calories from carbohydrates. These are the charts that I mentioned before about average daily weight gain. So for infants, let's say you have this is for boys, the one on the right is for girls. You have a 6 to 9 month old boy. He should be gaining 15 grams a day. So if you go see him Monday when he's admitted and you go back the next Monday, you want to see exactly how much weight he's gained, divide it by 7, and you want to compare it to that 15 grams a day. If it's only 7 grams a day, he's not gaining enough weight. So you need to do something. You need to put an intervention in place, increase his calories or increase the volume of formula or breast milk. Okay, and the growth charts are based on these numbers. So that's where they get the growth chart, is from these average daily weight gain numbers. For fluid requirements for infants, if they're getting breast milk or if they're getting formula that's properly prepared, they should be getting plenty of water. Remember, if you're boiling water to add to formula, you want to measure the water after you boil it before you add it to the formula, right? Not before, because if you do it before, some of it can evaporate, and then you're going to have a more concentrated formula at the end. And that can be very serious. That can cause dehydration. So make sure you're measuring the water after you boil it. They may need extra water. You know, we live in a very hot, humid climate in Florida. We drink extra water in the summer when it's 90 degrees out. They need extra water when it's hot and humid out. To assess hydration status, you can look at their number of wet diapers. It should be around 4 to 6 a day. Could be more. You want to look at their sodium levels. If they're dehydrated, they could be hypernatremic. If they have water intoxication or they're overhydrated, they could be hyponatremic. You want to make sure that caregivers are not replacing formula with water, because that could lead to water intoxication, and that they're not diluting the formula, trying to make the formula last longer and diluting it with water, so that can lead to water intoxication, and of course that's gonna make them fall off the growth chart too. They're gonna start getting failure to thrive and losing weight. For a few minerals that we want to look at specifically for infants, fluoride. Breast milk is really low in fluoride. So once they get to about 6 months where their teeth start erupting, they're going to need a fluoride supplement if they're exclusively breastfed. Formula has fluoride added to it. Breastfed infants need another source of iron by about 4 to 6 months of age, which usually is not a problem because at that time you're going to start introducing cereal. Cereal is iron fortified. Remember, cow's milk is a very poor source of iron. Breast milk actually is a poor source of iron also, but it has more bioavailability than cow's milk of iron. So they're going to get the iron fortified cereal at 4 to 6 months. And then studies show us, we know that chronic iron deficiency actually correlates with long-term developmental deficits and behavioral issues in early adolescence. So want to make sure they're getting enough iron, whether it's through a supplement, something like a polyvisol vitamin supplement, or they're getting that cereal. And then there's a few vitamins that are a concern for infants. Vitamin D. Breast milk contains adequate amounts of all the vitamins except for vitamin D. So it only contains about 20 international units per day for vitamin D in breast milk, and they need about 400. So they're going to need some type of supplement for vitamin D. And if they don't, they can develop rickets, which is vitamin D deficiency in children. So want to make sure breastfed infants are getting another source of vitamin D. Again, they could get that polyvisol, the liquid vitamin. B12 deficiency is not usually an issue unless the mom is a really strict vegan and is breastfeeding, the infant's exclusively breastfed, but usually not an issue. Vitamin K, babies are born with very small amounts of vitamin K, so that's why hospitals give them that vitamin K injection at birth. That's kind of a prophylactic measure just to make sure that they're getting that vitamin K. Otherwise, they can get bleeding or hemorrhaging, so we don't want that. So they get that vitamin K shot right at birth. Okay, breast milk or human milk is unquestionably the food of choice for the infant. Its composition is designed to provide the necessary energy and nutrients in the exact appropriate amounts designed for the infant. So it has a lot of benefits, which include the immune factors that it contains, which support and strengthen the immune system. Breast milk is easily digestible and more highly bioavailable. So like for instance with iron, even though cow's milk might have more iron than breast milk, it's more bioavailable in the breast milk. Breast milk helps to prevent diarrhea and otitis media, which are ear infections. Allergic reactions to breast milk are rare. They can happen, but they're very rare. And of course, the physical act of breastfeeding enhances the bonding between the mom and the baby. And then the economic benefits, pretty important, very cost effective, right? Compared to purchasing formula. So during that first few days of life, the breastfeeding infant receives colostrum from the mom. So that's a clear, transparent, yellowish fluid that's in the breast milk. And it helps meet that infant's needs during that first week, those first few days really. So it contains less fat and carbohydrates, but more protein than mature breast milk. And it also contains higher concentrations of sodium, potassium, and chloride than mature breast milk. It's a really, really good concentrated source of those immunologic substances. The immunoglobulin A, which helps protect the immature gut function. The lactoferrin, which helps to slow bacterial growth, and then the lysozymes, which actually can destroy bacteria. So because of all those factors, there's plenty of studies out there that show that breastfed infants have less infections than formula-fed infants. The Academy of Nutrition and Dietetics and the American Academy of Pediatrics support breastfeeding for the first 6 months of life. And then after that, continue breastfeeding, but it should be supplemented with some type of complementary foods. You're starting to introduce cereals and fruits and vegetables, and then continue breastfeeding until 12 months. That's the recommendation. Okay, there are 2 types of protein that are found in breast milk and formula, whey and casein. The whey protein is a lot easier to digest, and that's why it's the preferred protein for premature infants, because they have that immature gut, so the whey is a lot easier for them to digest. Casein can actually irritate the GI tract and cause a GI bleed, which can lead to anemia. Too much casein can cause these hard curds or rocks in the infant's stomach, so that can lead to the GI bleed, and it actually can cause an obstruction. There are a lot less allergies that are associated with whey protein than casein. And just to give you an example, breast milk is about 60% whey and about 40% casein. So I've also seen 70-30, probably just depends kind of on the mom, I guess, but more whey to casein in breast milk. And so with formulas, they're always trying to mimic breast milk, so formulas are about the same, about the 60-40 or 70-30 whey to casein. There is a formula called Good Start that's made by Gerber that's 100% whey protein. So they market it as it's much easier to digest. It's 100% whey. We don't recommend cow's milk until the infant's at least 1 year, and that's because cow's milk has too high of a renal solute load. So that means it has too much protein and too many minerals for that infant to tolerate. So it's much higher than the breast milk or formula. So it can lead to renal failure, dehydration. It's just too concentrated, and they can't concentrate it with those immature kidneys yet. So at 1 year of age, their kidneys are able to do that, but not before. The whey to casein ratio for cow's milk is 20-80, so it's 20% whey to 80% casein. So they're just not ready to digest that yet either. Cow's milk, although we know it's a great source of calcium, vitamin D, phosphorus, protein, it doesn't have enough vitamin and minerals to be the sole source. So they need the formula or the breast milk. It's very low in iron, it's low in pretty much all of the other vitamins, vitamins C, A, E. There's not enough fat in low fat or skim milk to provide the amount of fat they need for calories, and then also the essential fats. So cow's milk not appropriate until at least a year of age. Just to give you an idea of osmolality of some of the different fluids, breast milk is 273, can vary a little bit. And then formulas, again, they're made to mimic breast milk, so they're going to be right around that same number. They could be a little bit lower. There are some lower osmotic formulas out there. Whole milk is 389, so it's too high for infants to tolerate. They need to be closer to that number for breast milk, that 273. Goat's milk is also a little bit high, 339. Caro syrup, which a lot of times you might see a caregiver give their infant a little bit of Caro syrup in the formula to sweeten it, because they think that will get them to drink it, because if they don't like it and they sweeten it, then they're going to like it. But it has extremely high osmolality. As you can see, it's almost 2200. So if they're giving them a lot of that, that can cause them to have a lot of diarrhea. They're not going to tolerate the formula, and that can lead to dehydration, so it can be very serious. So at least 6 months before they would do any type of Caro syrup. Fruit juices are pretty high, and you can get some that are lower, but most of them are pretty high. And then soda, of course, which is not appropriate for an infant, but is also very high. So those things, if those are given on a regular basis, could be pretty detrimental. Okay, there are a couple different forms of infant formula. They can be cow's milk based or soy based. And the infant can receive formula along with breast milk. So, for whatever reason, maybe the mom can't produce enough breast milk. So they may need also some formula. So you may see an infant that gets both simultaneously. The FDA does regulate infant formula manufacturing. There's an Infant Formula Act, so that makes sure that it meets certain nutrient needs and follows certain guidelines. They do add the DHA, the ARA, the essential fats, the prebiotics, the probiotics to formula, again, so that it mimics breast milk. And we have seen a decline in anemia in infants because we've been adding iron to formula now, so that's a good thing. Casein hydrolysate, which is just casein that's split into smaller components, is used as the protein part for some of the hypoallergenic formulas so that they can better tolerate those formulas. They're a little more expensive, but better tolerated for some infants. It's extremely important as a dietitian to understand the different forms that formula comes in. So there's ready to feed, there's concentrate, and there's powder. The ready to feed is just like what it sounds like. You can literally open it up and feed it to the infant. So it doesn't require adding water or any type of preparation. And because of that, because it's the most convenient and easiest, it is pretty expensive. So it's typically not the formula that parents are going to be buying. They do use it a lot in the hospital and the NICUs just because it's more convenient. You can literally just take the cap off, and there are nipples that are made to put right on the bottle, and you can feed it right to the infant. So, but it's the most expensive. Concentrate comes in a 12-ounce can. You have to add water. You have to add 12 ounces of water to the 12 ounces of concentrate, so 1-to-1 ratio, okay? And that will make your standard formula, which is 20 calories per ounce. If you don't add any water, that concentrate will be 40 calories per ounce, so it's going to be twice as many calories, which you can just imagine if the caregiver's feeding that liquid without adding water to the infant, they're going to get a lot of calories, too much protein, they're going to get dehydrated, it's going to have too high of a renal solute load, and it could actually cause kidney failure. So really important to ask, how are you making that formula? How much water are you adding? Are you adding water? About 1 can of concentrate liquid should last about 3/4 to 1 day. So if you ask, okay, you're using the concentrate, but they tell you that they're going through 2 cans a day, that should be a red flag that they're getting way too much. Maybe they're not adding enough water. So you want to have them walk you through how they're making that formula. The powder, I think it's the most cost effective. Yeah, it's the least expensive of the 3. A scoop of powder to every 2 ounces of water will make 20 calories per ounce. So if you want to make 6 ounces of formula, you add 3 scoops of powder. And 1 can of powder should last 3 to 4 days. And that's a lot easier to travel with. If you're on an airplane, you can just bring the powder and then get water. So you want to ask again, how long is that can of powder lasting you? And if they say, oh, it's lasting me a week, well, there's a problem. They're not getting enough. Something's wrong. So you want to ask how they're making it. This just shows you what the different types of formula will look like. So these 2 on the left here are your ready to feed. So you literally just take off the cap and you can feed it right to the infant. You can pour it in a bottle or attach a nipple. The can in the middle is your concentrate, your 12 ounces that you need to add another 12 ounces of water to. And then on the right are your 2 powder forms. So again, that's 1 scoop to 2 ounces of water. There are a lot of different special formulas out there, probably hundreds and hundreds. There are soy-based formulas, lactose-free formulas. There are metabolic formulas, like your PKU patients that need phenol-free formula. There's hundreds of metabolic disorders, so there's hundreds of metabolic formulas out there. Your hypoallergenic formulas that use that casein hydrolysate, like progestamol. Human milk fortifier, these are the little packets down here that you add to breast milk, adds calcium and phosphorus to breast milk. That's just what some of those look like. When you're preparing formula, you always want to do it in a clean environment as much as possible, and you never want to microwave formula. That's because when you microwave things don't get heated thoroughly, so you get those hot spots. We know that when you microwave food, you get kind of parts of it are cold and parts of it are hot. So just think about the infant that's going to go drink that formula, and they could get a real hot spot and they can burn their mouth. So you don't want to ever microwave formula. You want to warm it in a hot water bath. And then you're going to boil water if you're using tap water for a couple minutes. Or you can use bottled or distilled water. Remember, if you're boiling, measure it after you boil it. Formula can be prepared for up to a 24-hour period. It needs to be kept refrigerated, and then you warm it before you use it. And any formula that isn't used within that 24-hour period should be discarded. Okay, so how do we get a diet history for an infant? We get diet histories from adults just by asking them, what did you eat? For an infant, we need to interview the caregiver, the parent, to find out. The very first question you want to ask is, Are you feeding formula or breast milk? So if they're giving them formula, is the infant being breastfed? So is it every 3 hours? Is it every 4 hours? Are they doing it at night? How long on each breast? So is it 5 minutes? Is it 10 minutes? Is it 15 minutes? And then again, you can ask about the wet diapers. That should be around 4 to 6 a day. And then the solid diapers, that can vary depending on the infant and depending on if they're breastfed or formula fed. They're usually softer with breastfed and a little more firm with formula. It depends on their age. The younger they are, the more they have. But they should be having solid diapers every day. So you want to ask those questions, and that can help. Okay, when you're transitioning, when they reach that 1 year point, we want to try to transition to cow's milk, but not before. It can cause GI bleed. That cow's milk has excessive protein, sodium, and potassium. It doesn't have enough iron or linoleic acid, so that's why we wait till 1 year of age. Low-fat and non-fat cow's milk also, we don't want to do that for the first year. You can start transitioning to that at 2 years, but for that first year, when they hit age 1, it doesn't provide enough of those essential fats and calories, so they still need that whole milk at 1 year of age. You want to try to avoid rice, oats, some of the nut milks like almond milks until they get 1 year of age, and then they're appropriate. Just make sure you're getting one that's supplemented or fortified with vitamins and minerals. And then at about 2 years, you can transition to 2% or skim milk. But I wouldn't do that if the child was underweight, so you want to still get those extra calories from whole milk if they're having weight issues or if they don't take a lot of milk anyway. Solid foods, the first solid food you want to introduce is infant cereal around 4 to 6 months. And you can mix that with formula or water. It's usually fortified with iron. You want to feed it by spoon, not in a bottle. Strained fruits and vegetables are next. Those are good sources of vitamins. You want to always introduce one at a time, because if you give them 3 different brand new fruits and vegetables one day and they have an allergic reaction, you don't know which food it was. So you just want to do one food at a time for a few days. Make sure they don't have any type of reaction. Then you can try another food. You want to try to do vegetables before fruits, just because they like the fruits better because they're sweeter, and then they won't take the vegetables. So give them their vegetables when they're hungry, and then give them their fruits afterwards. Meats, strained meats are good sources of protein and iron. Start introducing those. Dessert items, just keep in mind they have a lot of extra calories from sugar and cornstarch and tapioca, and those aren't very nutrient filled, so we want to limit those type of foods. There's a lot of organic infant foods on the market now, and then you can also do home prepared infant foods, which is a good idea because then you're not getting the preservatives, and also you're not getting as much water. They add water to infant foods, so when you make it at home, you're getting more nutrient concentrated infant foods. Okay, and then juice, no more than 4 to 6 ounces a day, and that should be given by sippy cup. We don't want to replace food with juice. That can lead to failure to thrive. We want to encourage infants to feed themselves as much as possible, whether they're just picking up foods or feeding or drinking with a sippy cup. Cut foods into small pieces so they can pick them up, and then also that is going to decrease the risk for choking. Don't force children to eat. Don't overfeed them. They'll let you know when they're hungry, and they'll eat when they're hungry. And then try to offer a variety of textures and flavors and colorful type foods. Okay, low birth weight infants is kind of the next section. So this is your premature infants. They have a whole lot of different nutritional considerations than your regular full-term infant. Most preemies or premature infants do have the potential to live a long and productive life. There's just some special considerations in this first few months and maybe year of life. The nutrition requirements will be determined based on their size, how much they weigh, their age, are they born at 28 weeks, or are they born at 32 weeks, and their clinical condition, so what's going on clinically. The NICU, just some terminology, is your neonatal intensive care unit, so that's where these infants will be. The preterm birth rate in the US back in 2007 was about 12.7%. And then just some terms, if you see low birth weight, that's an infant that weighs less than 2,500 grams at birth. So that's 2.5 kilograms, that's roughly 5.5 pounds. Your very low birth weight infant weighs less than 1,500 grams at birth, which is 1.5 kilograms, so that's a little over 3 pounds. And then your extremely low birth weight infant weighs less than 1,000 grams at birth, so that's 1 kilogram, and 1 kilogram is 2.2 pounds, so that's a really small baby. Low birth weight can be attributed to shortened period of gestation, which is prematurity. Also can be due to restricted intrauterine growth rates. The definition of gestation is just the period of time from conception until birth. So that's gestation, okay? So a full-term infant gestation will be between 37 and 42 weeks, okay? We usually say full-term is about 40 weeks, but technical definition, anywhere between 37th and 42 weeks. A premature infant or preterm infant is going to be born before 37 weeks, and then a post-term infant is going to be born after the 42 weeks. Okay, preterm infants, there is a special growth chart that's designed for them. You can use this. You can also use the regular growth charts, and I'll tell you how to do that in a second. But the preterm growth chart, as you can see on the bottom, the gestation age starts at 24, or actually 22 months. So you're going to actually plot them at their gestational age, and they should fall into that curve for weight, head circumference, and length. But if you want to plot them on the regular growth charts, you can. You just need to adjust their age, okay, based on how premature they were. So this is how you do that. First, you calculate the number of weeks that the infant was premature. So 40 weeks, we're going to say, is term. That's a full-term infant. Let's say they were born at 28 weeks gestation. Okay, so 40 minus 28, they were 12 weeks premature, which is 3 months. So that's going to be your correction factor, that 12 weeks of being born, 12 weeks too early, basically. So then you're going to calculate the adjusted age for prematurity. So you're going to take their chronologic age, was how old they are today. Let's say they were born 4 months ago, so they're 4 months old today, okay? Then you're going to subtract that correction factor, that 12 weeks. So you're going to take that 4 months minus 12 weeks, which is 3 months. So 4 months minus 3 months is 1 month. That's their corrected age. So even though they're really 4 months old, their weight and their length is the same as a full-term infant at 1 month. Does that make sense? So that's how you would adjust for their gestational age. And here's just that same example down here. So, and then you can take that 1 month, plot them at 1 month on their regular growth chart with their actual length and weight, and they should be on that growth chart. You just want to make sure, in your note, you're saying that you did adjust for their gestational age. And you'll usually see that abbreviated as AGA, adjusted for gestational age. Okay, so most nutrients are deposited during that very last trimester of pregnancy. So if you have an infant that's born prematurely, they're born in a compromised state of nutrition because they're not getting most of those nutrients in that last trimester. So for example, fat in a preterm infant, only weighing about 1 gram, they're only going to have about 1% total body fat. But a full-term infant weighing 3,500 grams would have 16% body fat. So that's a huge difference. So they just don't have those stores that a full-term infant is born with. The preterm infant will very rapidly run out of fats and carbohydrates. So that's why we need to immediately start some type of nutrition support, okay? So usually either enteral or parenteral is going to be started day 1. If you have a very low birth weight or extremely low birth weight infant, it's usually got to be parenteral nutrition because their GI tract is just too immature at this point to tolerate enteral. So they're going to be started on parenteral nutrition. And you'll see the TPN rates in the NICU running at 2 cc's per hour, and that's their goal rate. So very different than adults. With your preemies, there are a lot of different clinical conditions that can happen. because they're born prematurely and things just didn't have a chance to fully develop. So, and you can have a lot of these happening simultaneously. So as far as respiratory, which is probably the biggest one, because their lungs don't have a chance to fully develop, they can have respiratory distress syndrome, chronic lung disease, BPD, which is bronchopulmonary dysplasia, and then they may not, their lungs may not produce surfactant, which is that fluid that helps keep the lungs kind of more flexible and reduce surface tension. So major respiratory issues. A lot of these preemies are born and have to be immediately on a ventilator to breathe until their lungs can mature a little bit more. Cardiovascular, there's a condition called patent ductus arteriosus, which is PDA, so they can be born with this condition that has to be surgically repaired. There's a blood vessel called the ductus arteriosus that allows blood to go around the baby's lungs before birth. So usually a couple days after they're born, that ductus arteriosus closes. But if they're born prematurely, it doesn't close, and that's going to cause abnormal blood flow from the pulmonary artery to the aorta. So that can be a big issue, and that has to be repaired surgically. That's an open heart surgery. Renal issues. They have immature kidneys that can cause fluid electrolyte balances. And when you're talking about a 2-pound infant, that fluid and electrolyte balances can be very dangerous. They can have intraventricular hemorrhaging, which is bleeding in the brain, hyperglycemia, hypocalcemia, metabolic acidosis, hyperbilirubinemia, feeding intolerance. They may not have swallowing and sucking function developed yet. NEC, which is necrotizing enterocolitis, which is just what it sounds like, inflammation and ischemia of the gut. So the gut isn't able to digest and absorb, and that part of the gut usually has to be surgically removed. Anemia, sepsis, pneumonia, meningitis. Their immune system, they're born in compromised immune status, so they're more susceptible to these infections. Bradycardia, apnea, cyanosis, and we'll talk about osteopenia of prematurity. Several of those things could be happening with these premature infants. Okay, so they may have difficulty progressing to full enteral feeding in the first several days or weeks because they have, remember, that really small stomach capacity. They have an immature GI tract, and then whatever of those illnesses from that previous slide that they have going on. So a lot of times they have to be on parenteral nutrition just to meet their needs for a while until they can start tolerating a little bit of enteral. And of course, we want to get them started on enteral as soon as possible, just to stimulate those GI enzymes. Helps to promote bile flow so they don't get the cholestasis, the backup of the bile. It helps to increase the villus growth in the small intestine, and then promotes mature GI motility. So as soon as possible, we want to get some enteral nutrition started, which can be breast milk, or it could be formula. Fluid needs for these preemies, if they're not getting enough fluids, they're going to be at risk for dehydration, electrolyte imbalances, which can be serious, and hypotension. If they're getting too much fluid, edema, congestive heart failure can develop, and that ductus arteriosus, it can cause that to open back up. So we're going to be real careful with fluid. Large amounts of insensible water is lost in infants because they have such a large surface area compared to such a very small body weight. So just a few pounds compared to that surface area of all their skin. So that's why they use the incubators and the thermal blankets to help prevent so much of that insensible water loss. So that helps with their hydration status and fluid balance. So usually we start fluid at 80 to 105 milliliters per kilogram per day for the first day of life. That helps to meet those insensible fluid losses. By the end of the second week of life, we're going to bump that up to 140 to 160 milliliters per kilogram per day. Okay, so they're going to have even higher fluid needs than a full-term infant. Maybe less if they have CHF or renal issues, or they have that PDA. So there are situations where they may actually need a fluid restriction. Okay, so the next couple slides are regarding parenteral nutrition needs for the preterm infant, and then I have a couple slides for enteral nutrition needs for the preterm infant. So they're different, okay? And that's because with parenteral nutrition, we're feeding them right into their blood system. It's already going to be 100% absorbed. But when you're feeding them enterally, just because of the digestion and absorption, they're going to lose some of those nutrients. So they have a little bit higher needs enterally than parenterally, where you're bypassing the entire GI tract. So for energy needs for parenteral nutrition, and with adults, yeah, same thing, but we just don't care as much because, you know, there's a little more wiggle room and room for error, but there's not with an infant that's 2 pounds. So there's, the difference becomes significant with this population. So the energy needs are 30 to 50 calories per kilogram for the first 3 days of life, and then increase gradually to 90 to 100 to support growth. For parenteral, you'll see with enteral it's a lot higher, because it's with parenteral it's going right into the bloodstream, bypassing the GI tract. Your amino acids, 1.5 to 3 grams per kilogram per day initially, and then in general, the goal could be anywhere from 2.7 to 3.5 grams per kilogram. Some of the extremely low infants could be up to 4 grams per kilogram. Just want to monitor their labs, make sure they're tolerating it. With lipids, they need the lipids to get the essential fats, and lipids are a real concentrated source of calories too. So you want to start at 1 to 2 grams per kilogram and then advance to a goal of about 3 grams per kilogram. Carnitine is added to parenteral nutrition usually with these infants because they don't have the ability to produce carnitine, so they'll add it right to the TPN. Okay, with glucose, premature infants have poor glucose tolerance, and that's because they're not producing enough insulin. You know, their pancreas is immature, their GI tract is immature, and they may have some insulin resistance. So you really want to watch their glucose levels. You want to monitor for hyperglycemia. It's better to give glucose with amino acids. It's going to help keep their blood sugar more controlled, because the amino acids actually stimulate insulin production. So instead of giving glucose alone, you want to give it with amino acids. And you want to calculate glucose load on this population for sure. Make sure you're not giving them too much, because if they get too much glucose, that can cause dehydration. So your initial glucose load is going to be 4 to 6 milligrams per kilogram per minute. And remember, there's 1,440 minutes per day. So you got to get their weight in kilograms and calculate that out and make sure you're not exceeding that. Then you can advance the glucose by 1 to 2 milligrams per kilogram per minute per day. And then the maximum, you don't want to go above 11 to 12. And just like with adults, you don't want to start at 11 to 12. You want to build up slowly, and then you don't want to stop abruptly either. You want to wean them, okay? Enteral nutrition. These numbers are a little bit different. They're going to be a little bit higher, just because of the loss of some of the nutrients through the GI tract. So 50 calories per kilogram for the first few days of life, then you're going to increase up to 105 to 130 calories per kilogram. Some preterm infants might actually need more than that 130, so you have to monitor, make sure they're gaining weight like they should be, and if they're not, then you need to bump it up. Their feedings may need to be concentrated to more than 24 calories per ounce, because they may not tolerate enough volume to get in the calories they need. So you need to come up with a recipe to concentrate their formula to make it higher calories per ounce in a smaller volume, okay? You can concentrate up to 30 calories per ounce. For protein, 3.5 to 4 grams, so that's higher. Whey predominant formulas are better for this population because of their immature GI tract. So that's going to be easier for them to digest. Formulas for preemies are designed to be higher in cysteine because preemies are born with lower levels of cysteine and have a harder time making cysteine in their body. And preemie formulas are designed to be lower in phenylalanine and lower in tyrosine. That's because preemies have difficulty breaking those down, okay? So there are special formulas for premature infants, which we'll talk about. Too much casein can irritate the GI tract again. So that's why, again, for your preemies, you want to use maybe those 100% whey formulas may be a good one for the premature infants, but they have specialized formulas. For lipids, fat should constitute about 40 to 50% of their total calories. Essential fats are added to premature infant formulas because they have less fat stores. The linoleic acid, the essential fat, should compose about 3% of their total calories, and then alpha-linolenic is going to be in smaller amounts. ARA and DHA are added to formula because that's in breast milk. Some of the medium-chain triglycerides are probably more appropriate because they're more broken down and easier to digest for these preemies. They have less of the enzymes and the bile salts to break those down, to break down the fats. So, for carbohydrates, total calories should be about 40 to 50% from carbs. Infants that are born before 28 to 34 weeks gestation may have lower lactase enzyme activity. So just keep that in mind. They might not tolerate formula with lactose right off the bat, and it's just a temporary thing usually until they can develop those enzymes. So they might need a lactose-free formula just initially. Okay, osteopenia of prematurity. These infants are at a very high risk for this condition, and that's because 2/3 of the neonate's calcium and phosphorus is deposited during that last trimester, those last 3 months, and they're being born, 28 weeks, 38 weeks gestation and missing out on that, okay? So they're gonna be at really high risk for osteopenia. And we know you need calcium and phosphorus and also vitamin D for bone mineralization. So early parenteral nutrition and enteral nutrition, human milk fortifier, and the specialized preterm formula, all of those have been associated with a decline in the incidence of metabolic bone disease in these preterm infants. So that's why these infants, it's really important that they get that special preemie formula because it's got more calcium, it's got more phosphorus, it's got more vitamin D, it's got more of what they need to prevent osteopenia. If you give a premature infant a standard formula, they're going to be at risk for getting osteopenia of prematurity. If you give a premature infant breast milk without adding the human milk fortifier to it, they're going to be at risk for osteopenia. Okay, so very important to supplement with the human milk fortifier or give them that special preemie formula. Okay, these are just some examples of formula. Your standard formula is 20 calories per ounce. Enfamil, Similac, Good Start, those are the 3 main ones. Your preemie formulas, some of them come ready to feed in 22, 24, and even 30 calorie per ounce. So again, they're already ready to feed, and that's usually what they use in the NICU, unless they're on a special formula. But Enfamil Premature is an example of one, Similac NeoSure is an example of one. But these are your ready to feed, there's a powder and there's concentrate. So the method for which these infants are going to be fed just depends on their clinical condition, really. So, how premature are they? So ideally, we want them to breastfeed or take a bottle. So if they're at least 32 to 34 weeks, usually that's realistic. They're usually fairly medically stable, and they can take, from a bottle or breast. If they're less than that 32 weeks gestation, though, there's other methods that we might need to use, such as the gastric gavage. So this is where you take a flexible, kind of soft feeding tube, and then you're going to enter it in through the nose or the mouth. It's going to go down into the stomach, and it's kind of like a forced feeding. So you're giving them through a syringe or a feeding pump a volume of formula or breast milk through that tube. So that could be in addition to breastfeeding. Maybe they can't get enough by breastfeeding, so we have to do several of these feedings a day in addition to meet their needs. You can do bolus feedings. They may need a surgically placed feeding tube, a gastrostomy, if this is going to be a long-term thing that we anticipate they're not going to be able to take formula or breast milk by mouth. And then a transpyloric feeding tube may be indicated with these premature infants because they're at such high aspiration risk and they tend to have delayed gastric emptying as well. So both of those are really common with this population. So that transpyloric feeding tube, remember, it goes through past the pyloric sphincter, past the stomach. So it feeds into the upper part of the small intestine, the duodenum or the jejunum. So that's better for those babies that are at risk for aspiration. Also, your severe reflux babies, which that's common with this population too, they might do better with the transpyloric feeding. So there's a lot of different methods, kind of depending on their clinical condition. Okay, so selecting the type of enteral feeding. Human milk is ideal if possible. When we compare human milk to premature infant formula, we did see a reduction in the incidence of neck and sepsis, improvement in neurodevelopment. It facilitated a more rapid advancement of enteral feedings and then led to an earlier discharge. So, but remember, for these premature infants, that human milk needs to have that human milk fortifier added to it so they can get that additional calcium and phosphorus. But that would be the ideal feeding if possible, and you can give that through a feeding tube. The mom would just have to pump or express the milk. Okay, so formulas can be concentrated to provide more calories in a smaller volume. So we do this by adding less water to the formula, to the powder, or to the concentrate. If you add less water, it's going to make it higher calories per ounce, right? But very important that this recipe is only coming from a registered dietitian who's done all of the proper calculations to make sure that that's going to be okay. So we don't want, parents concocting their own recipe and concentrating their own formula, okay? So that recipe needs to come from you. You need to calculate that baby's renal solute load and what they can tolerate, and then make sure that that concentrated formula is acceptable. You need to figure out what their fluid needs are and make sure that amount of formula is going to meet their fluid needs. Infant formula powder is actually not sterile, so we don't usually use that with this population if at all possible. So we're going to use the concentrate or the ready to feed. And there are a lot of different additives to increase calories in formula. So standard formula 20 calorie, preemie formula comes 24 calorie, but we can actually make it even higher. If they're only tolerating a certain amount, we can bump up those calories. So these are some of the different additives that can increase total calories in the same volume. So the first three are different fat additives. So you're just keep in mind though, when you're adding these things, you're adding fat or a carbohydrate or protein, you're changing the whole distribution of nutrients, okay? So you need to really think about that infant and what's going on with them. And let's say they have renal failure. Well, we're not going to give them more protein as their additive. We're probably going to do, a fat or carbohydrate. So you got to think about what's going on because you're changing that whole nutrient distribution, right? And you could give them one of these or two of these or three of these to keep that nutrient distribution more in balance. So the MCT oil is used for infants that might have fat malabsorption because it's the medium chain triglycerides. You don't want to give it as a continuous tube feeding because it can actually coat the inside of the feeding tube and can cause a clog. But it's okay for a bolus feeding or the gastric gavage. Microlipids is another fat additive. It's made by Nestle. It can be used for continuous tube feed, so it doesn't tend to coat the inside of the feeding tube. It's really expensive though. It does require refrigeration after you open it. And then corn oil, you can use that. You can use that with a formula that's going to be fed by bottle or bolus. Shouldn't be run continuously either, again, because it can coat the inside of the tube. It can be used with respiratory compromise when we're trying to get maybe more calories from fat to keep that respiratory quotient lower. And all of these fat additives can delay gastric emptying. Remember, fat delays gastric emptying. So if they're having issues with that or reflux, we might not want to add fat to increase their calories. We might want to do carbohydrate or protein additive instead, okay? Caro syrup can be added, but again, we want to wait till they're at least 6 months because of the high osmolality of caro syrup. You know, and if it's an infant that's having issues with diarrhea and GI, caro syrup might not be the way to go with that infant. Polycose is a carbohydrate modular made by Abbott. So that's used a lot of times for infants that have reflux, because you don't want to give them a fat additive that's going to delay emptying. So you're going to give them a carbohydrate. Also for dysphagia, it does have a high osmolar load, so you just want to remember that. If it's a baby having issues with, you know, maybe diarrhea, then that might not be the way to go. But if they're having constipation issues, maybe that is the way to go. So got to kind of look at the big picture. And then ProMod is a protein supplement. It's also made by Abbott, just to increase the protein content. So you could potentially concentrate a formula up to 30 calories per ounce and use a fat, a carbohydrate, and a protein, and kind of keep that distribution equal. Okay, and again, this recipe should be from the dietitian. Okay, when that preterm infant gets ready to go home, the caregiver or the parent needs to be ready to make that formula, and they need to have a recipe that is given by the dietitian, and that needs to be written down, a written recipe of exactly how much, you know, how much microlipids to add, how much ProMod, how much water, how much of the concentrate formula. And you want to, if you can, I know a lot of pediatric hospitals will give measuring utensils to them to take home, so they can't, you know, because they're going to have measuring cups, teaspoons, tablespoons to measure all these things appropriately. Sometimes syringes, if it's like 5 cc's or 7 cc's, they're supposed to add, so they need the proper measuring equipment also, and a written recipe, and you know, instruction how to make that formula and how much of that formula that baby needs in a 24-hour period, so they have a goal amount. The dietitian can work with the social worker to make sure that the caregiver can get the formula. If they're on a special formula, like a Premature formula, you can't just go to the drugstore and buy that off the shelf. So there needs to be arrangements made to get that ordered from the pharmacy or from WIC, and WIC will provide most of these special formulas and metabolic formulas, but they're going to require a doctor's prescription and probably some other WIC paperwork. Medicaid will also usually help with providing formula and those additives. Some of those additives are very costly, but again, they're going to need paperwork, so that's kind of part of the dietitian's job as well. It's getting that prescription from the doctor, the diagnosis that indicates the need, and then certain paperwork. I know Medicaid has certain paperwork too that you have to fill out. And making sure they get that done before they discharge, because of the day they discharge and then they're just starting to get this paperwork done, it could be a week before they get their formula. So a lot of times you'll send them home with a little bit of formula too to last for a couple days. But get that in place before they get discharged. Sometimes dietitians and nurses will visit the baby at home just to make sure everything's going okay, but they're definitely going to be following up with their pediatrician. You know, they're going to be looking at them on the growth chart, making sure they're gaining weight and growing like they're supposed to. You know, with these preemies, they may have, you know, BPD or lung issues, and they're going to also follow up with the pulmonologists. And pulmonologists a lot of times have dietitians in their office, so they may be coming to see the nephrologist or the cardiologist or feeding specialist. And a lot of those with pediatrics do have dietitians that come consult on an outpatient basis. So just making sure that they're following on that growth chart, and maybe you sent them home with a certain recipe, and now they're back a month later, now we need to change that recipe. They need more calories, or maybe they need less calories, so making adjustments. I think that's a good place for a break. It's about halfway. Let's take a childhood and adolescent nutrition. Okay, so typically with this age group, their weight increases about 2 to 3 kilograms per year until they reach about 9 to 10. And then the rate starts to increase, which means they're starting to get approach puberty. Their height increases about 6 to 8 centimeters per year from about 2.5 years to puberty. And at this age, their growth can be kind of erratic, and they can have growth spurts, and that's totally normal. So you might see on the growth chart, it might look kind of zigzagged, but as long as in general they're following that curve, it's okay. Fat composition starts to decrease during childhood, but then as they get to puberty, what happens is adiposity rebound, and then that body fat starts to increase when they start reaching puberty. The earlier the adiposity rebound occurs, the more likely they are to have a higher BMI later in life. So for assessing growth for this age group, we're going to use those CDC growth charts, the 2 to 20-year-old ones. So we're going to plot their weight, their height, and their BMI. So for this age group, we do calculate BMI. If you just put one measurement on there, that doesn't really tell us very much. And a lot of times, sometimes measurements are inaccurate. So it really is more helpful if you have, 3 or 4, several measurements that you can try to determine a pattern over a period of time. And once in a while, you'll see everything's following the pattern, and there's this one that's way out of the pattern, and probably there was an incorrect height or weight there. So one measurement doesn't really tell us a lot. Regular monitoring of growth enables problematic trends to be identified. So if we can plot as many points on the growth chart, and then as soon as we start seeing a trend develop, we can address it. And when kids go to their pediatrician, they will always get their height and weight plotted on a growth chart. It's part of their medical record. So as soon as something is identified where they see an issue, a lot of times they'll refer to the dietitian. They'll actually make copies of the growth chart, send it with the patient, say, take this to your dietitian so they can actually see what's happening. Maybe they're gaining too much weight, or maybe they're plateauing or losing weight. We can also measure their mid-arm circumference to assess lean body mass. Remember the tape measure around the arm? We can do tricep skin fold to assess body fat percentage, and that's really, with pediatrics, that's probably the most common population that you would do tricep skin fold to assess their fat. And then you can do their average weight gain too, just like with infants. So here's the charts for children and adolescents for weight gain, for mean rates. So the left is for boys, the right's for girls. So for instance, a 5 to 6-year-old boy should be gaining about 192 grams per month. And that's about 2.3 kilograms per year. And this is what the growth charts are based on, these numbers. So you can, if you see that boy, every month, you can, see how much weight they're gaining, plot them on the growth chart, but also, are they gaining that 192 grams a month approximately? I gave you those equations in the very beginning, the Schofield, the Hu equations, the calories per kilogram. So you would use those for this age group too, for energy and for protein. And again, they're still growing, developing, they should be gaining weight. Protein deficiency really in the US is pretty rare. I mean, protein's pretty widely distributed and highly emphasized in our food supply. It can happen, but it's fairly rare. For this age group, there's a few vitamins and minerals that we do want to pay attention to, but they have their own DRIs for infants and children. They do have an increased risk for iron deficiency anemia from 1 to 3 years, and that's just because that's when they're growing the most rapidly. We need calcium for bone mineralization. Zinc deficiency. Zinc is mostly found in meats, seafood. Sometimes kids don't want to eat those foods, so they could be at risk for zinc deficiency. That's going to cause growth failure, poor appetite. Remember, zinc can affect taste acuity, and it can cause poor wound healing. Vitamin D is really important for this age group for bone mineralization as well. And then fluoride. A supplement may be needed if the child's over 6 months and they're not taking in any fluoridated water, okay? And really, a lot of juices are even made with fluoridated water now. So it'd probably be kind of hard to not be getting fluoride. You'd have to be trying to not get fluoride. The American Academy of Pediatrics does not recommend giving healthy kids any type of vitamin supplement. Okay? It's not like it's going to hurt them, but it's not necessary. If they're eating a pretty good, well-balanced, good variety diet, and they don't have any chronic conditions, they really don't need a vitamin. However, that being said, kids that are at risk for malnutrition really would benefit from a vitamin supplement. So there's a group of different situations where that would be recommended. But your healthy kid, in general, if they're eating good, they don't really need one. But certainly someone that's got anorexia, that doesn't have a very good appetite, maybe they're following some type of diet, like they're totally eliminating fat or totally eliminating carbohydrates, they would benefit from a vitamin supplement. A chronic disease, abuse, neglect, just not getting enough food, some type of a diet program, maybe they're on the ketogenic diet, they would need a vitamin supplement. Not getting enough dairy or failure to thrive. So there is some situations where a vitamin would be beneficial, but in general, not usually necessary. Okay, catch-up growth. So when a child is recovering from an illness, or if they've had an instance of undernutrition, and they've had slowed or ceased growth, which we would see on the growth chart, they're going to need extra calories and also extra protein to catch up, to get back on the growth chart to where they're supposed to be, okay? So that's called catch-up growth, and that's a calculation that I'll show you. So with catch-up growth, they should, if it's working properly, they should have a rapid increase in weight, length, and head circumference until they reach back up to that normal point on the growth chart where they should be. So we do this a lot with preemies and with infants with failure to thrive. So once the child does catch up to where we want them to be, then we need to readjust their needs again so they can slow back down and stay and maintain, normal growth. Okay, so to calculate catch-up growth, these are the steps. You're going to first just plot their actual height and weight on the growth chart, okay? You're going to see that their BMI for age or their weight for length is probably going to be below that 5th percentile. It's going to be off the growth chart, okay? And that's going to show you that they need to catch up. You're going to look back at that chart from the beginning of the presentation where it has calories per kilogram, the RDAs, and you're going to determine what their recommended calories and protein for age is. Then you're going to use the growth chart to determine their ideal weight at the 50th percentile for their actual height, and I'll show you how to do that. Then you're going to plug that into a formula, and you're going to multiply the RDA for calories times their ideal weight, divide by their actual weight, okay? This is what the equation looks like. So for energy, and you want to also do it for protein. So their calories per kilogram for their age times their ideal weight for their current height divided by their actual weight, and then same thing for protein. So that's the formula. So here's an example. You have, let's say, a 16-week-old infant. This is a girl. So her weight is 4.2 kilograms, and I know this is kind of hard to see, but she's 4 months. So she's plotting at 4.2. You can see her actual weight. She's way below the growth chart there. And then her length is 58 centimeters, so that's actually plotting in between the 5th and 10th percentile, so it's right there, okay? So then what you're going to do, if you do plot her weight for length, which is on the back of the growth chart, that's going to be below the 5th percentile or below the 3rd percentile also. So what you're going to do is you need to figure out what her ideal body weight is for her length. And the way you do that, and I know it's kind of hard to see on here, but you're gonna look at where her actual length plots, and you're gonna go directly over horizontally to where you meet that 50th percentile, and then stop. And I like to put a little circle there, and then it really helps if you have a ruler for this next part, because you're gonna go straight vertically down, and wherever you hit the 50th percentile for weight, that's her ideal body weight. So even though her weight is plotting down here, her ideal body weight is actually right here. So it's 5.2 kilograms. So you're gonna use that in that equation, okay? So here's the formula again. So her RDA for calories was 108. If you look back to that chart for 4-month-year-old, it's 108 calories per kilogram. You're gonna multiply it by her ideal body weight, then divide by her actual body weight. So that actually comes out to 134 calories per kilogram is actually what she needs for catch-up growth. So that's quite a bit more than the RDA, which is 108, okay? Obesity are certainly concerns for this age group. Just some statistics. Ages 2 to 19, about 16.9% have a BMI greater than the 95th percentile. 31% have a BMI greater than the 85th. And then ages 2 to 5, 10% have a BMI over the 95th percentile and about 21% over the 85th. And we do calculate BMI, but it's different than we do with adults as far as how we classify it as overweight or obese. So obesity, if that BMI plots at the 95th percentile or above, that's considered obesity for children. But if it plots between the 85th or the 94th percentile, that's considered overweight. Once it hits the 95th percentile, it's considered obese, okay? So there is a study that showed a lower prevalence of obesity with children that regularly eat their evening meal with their family, that get enough sleep at night, and that have limited screen time, so video games, TV, that kind of thing. And then a lot of overweight children you'll see are going to have cardiovascular issues like hyperlipidemia, hypertension, hyperinsulinemia also. You'll see fatty liver, those kind of things associated with kids with obesity. Iron deficiency is an issue, and we know that can affect their cognitive performance and behavior later in life. Food allergies are an issue with this age group. Sometimes they have multiple food allergies. And then physical inactivity, which really ties directly in with obesity. Okay, so the next section, I kind of tried to outline some of the more common pediatric disease states that you might see. These are just a few. Failure to thrive, and these are ones that all have pretty serious nutritional implications, okay? So I'm gonna kind of go through them, tell you what they are, and tell you what the nutrition implications are, okay? We're gonna talk about neck, gastroschisis, Hirschsprung's, intestinal atresia. These 4 are all affecting the GI tract. Congenital heart disease, cystic fibrosis, and then your BPD, those last 2 affect the respiratory system. Okay, so failure to thrive, and anytime, of course, that you see one of your patients in the hospital has a diagnosis of failure to thrive, that's someone that when you screen them, you're going to pick them up, okay? Because that's a definite indication that they're at risk for malnutrition. So, failure to thrive is a term. It's just used to describe infants and children that fail to grow and develop at that normal rate that we expect them to grow on that growth chart. They may have small head circumference, muscular wasting, apathy, weight loss, and poor weight gain. And they're probably going to need catch-up growth. So you're going to have to plot them on the growth chart, see how they're doing. They may need some catch-up growth. So they may need more calories, more protein. It's really important to try to determine what's causing the failure to thrive. And sometimes it's a mystery, but if you can determine if it's primary or secondary, or what in general is causing this infant to be falling off the growth chart. Primary, in my mind, means it's something that we can fix much easier. So it's usually just the infant isn't taking in enough formula, or the caregiver isn't preparing the formula, they're diluting it, so they're just not getting in enough calories for whatever reason. Those are things we can fix. We can teach them how to fix the formula properly. We can tell them they need more formula. We can get them to eat more foods. So those are originating from social and environmental factors. They're basically just not getting enough calories. And abuse, neglect type situations could fall into that category. Your secondary failure to thrive is usually due to a disease state. So someone has congenital heart failure, They have these super high calorie needs, and it's causing them to have failure to thrive. Cystic fibrosis, cancer, cleft lip. So some type of an actual disease state, and failure to thrive is secondary. It's caused by that disease state. Okay, necrotizing enterocolitis, like it sounds, is inflammation and ischemia of the bowel. So actually part of the bowel actually gets necrotic and dies. So it has to be repaired by surgery. That part of the bowel usually has to be removed, which is why this is the leading cause for short bowel syndrome in infants, because we're removing that necrotic part of the bowel. Serious, can be fatal. It can cause peritonitis, bowel perforation, and it does usually occur in those preemies and low birth weight infants. As far as intervention, they're going to need surgery. So right after surgery, when we need that bowel to rest, we're going to start parenteral nutrition for at least 2 or 3 weeks, maybe longer. And then as tolerated, you're going to try to transition to enteral feedings, and you can use breast milk as an enteral feeding. And then as they recover, you're going to do twice their protein needs and at least 25% more calorie needs, just for recovery and healing. They may do better with more frequent feedings. They may tolerate those better, and they probably are going to need an elemental formula that's more pre-digested, broken down, that they can more easily digest and absorb, like progestamol or Nutramigen, and they're more expensive, but these babies are probably going to need a formula like that. Okay, the next one is gastroschisis. That's how it's pronounced, gastroschisis. So it's a congenital defect. Congenital means it's something they're born with, characterized by an incomplete closure of the abdominal wall, and the intestines actually protrude to the exterior of the body, like you can see in that picture. So definitely requires surgery, stages of surgeries to get the bowel back into the abdominal cavity. Definitely going to need parenteral nutrition until those surgeries are done, and then they can start tolerating some enteral. Even after surgery, they might have some problems with feeding, digestion, absorption. They may need some of those elemental formulas. As far as causes for gastroschisis, I mean, it's fairly rare, but you will see it. The mother, if the mother is a smoker, is fairly young in age, or had any type of genitourinary tract infection during pregnancy, could increase the risk for gastroschisis. Okay, Hirschsprung's disease, this is another disease that affects the GI tract. So it's a condition where there's a congenital absence of those ganglion cells in the smooth muscle wall of the colon. So that's going to cause a lack of peristalsis somewhere in that intestine. It's kind of like essentially an obstruction in the intestine. So segments of the bowel actually become obstructed. That's going to lead to abdominal distension, can cause vomiting, constipation, diarrhea, growth failure, anorexia. They're not going to feel like eating. And that's going to cause weight loss. So a lot of nutrition issues with Hirschsprung's, and with Hirschsprung's, it can be very mild, and it can be very severe. So there's a whole kind of range for this disease. Usually, will require surgery to remove that part of the bowel that's obstructed. They might need parenteral nutrition if they've had a large amount of the bowel removed. They may be able to tolerate some enteral, maybe with parenteral simultaneously. They may be able to eat. They may be able to just take some high-calorie supplements. But I would say most of these, the more severe cases are not going to tolerate enteral nutrition or PO, and they're going to be long-time parenteral nutritioners. So I had a patient that had Hirschsprung's, very severe, on parenteral nutrition almost his whole life, and he actually got an intestinal transplant because that was really the only option. Intestinal atresia. So you can see with the picture on the right up there that it's basically a gap in the intestine that they're born with. It's a congenital defect. It can be in the small or large. It's usually in the small intestine, and it's characterized by narrowing or absence of a portion of the intestine. It's kind of like a gap. So it has to be surgically repaired, right? So they're going to need surgery to join that back together. So they may need parenteral nutrition until that surgery is done until that surgery heals properly. They're not going to tolerate any type of enteral nutrition with that gap in their intestine. And then start enteral feedings is tolerated after the surgery and after they get that peristalsis back, and then starting PO intake is tolerated. So after surgery, these infants should be able to tolerate a regular formula. Okay, congenital heart disease. This encompasses a lot of different birth defects involving, it could be the walls of the heart, the valves of the heart, the arteries or veins. And again, this is another one where you could have a pretty mild case of congenital heart disease and really have no issues whatsoever to very severe in need of a heart transplant. So there's a large range here too, just depending on what the actual defect is. It is the most common birth defect in the US, and it's caused by a developmental defect that actually occurs between weeks 5 and 8 of that pregnancy. Nutrition issues, really the main issue is that your heart is having to work that much harder to adjust for that defect, so they're going to have a lot higher calorie needs. So these patients are gonna probably need more calories per kilogram. Sometimes they have feeding difficulties, sometimes there's issues with breathing and feeding at the same time. Most likely, unless it's a really mild case, but they may need surgery to repair that defect. And a lot of times the surgeon doesn't want to do the surgery until they've gained enough weight. So that's where you come in, and you've got to bump up their calories and fatten them up and get some weight on them to prepare them for that surgery. It's a major, open heart surgery. Any type of assistance with feeding they might need, but you might need to give them a higher calorie formula before surgery to get them ready. Same with a heart transplant as well. If they do need that, they may need extra calories before that surgery. And sometimes the surgeon will have a specific weight in mind before they're going to do that surgery, so you got to get them to that weight. Cystic fibrosis, or CF. This is a disease characterized by really thick mucus secretions that come from epithelial surfaces of different organ systems, particularly the respiratory tract. It really affects the lungs. Also the GI tract, the liver, the genitourinary system, sweat glands, and it's caused by a mutation of the CFTR protein, or the CF transmembrane protein. It is the most common autosomal recessive disorder in the US, so that means, you can kind of see in that picture up in the corner, that both parents have to be a carrier of CF. And then they would have a 25% chance of the child being born with CF. So both parents have to be a carrier. Usually CF is diagnosed by the age of 3, but we're seeing more and more diagnosis is later in life, maybe even up to 18 years. About 1 in every 31 Americans are carriers, okay? But again, remember, you have to have both parents be a carrier for the child to have CF. So they've got to get that gene from both parents. And the median age of survival, which is the sad part with CF, is only about 37 years. The pathophysiology for CF, there's a lot of nutrition implications. So because of those thick viscous secretions, eventually you're going to have obstruction of glands and ducts. Those secretions just obstruct glands and ducts, particularly the respiratory system. So the lungs, have mucus building up inside of them, and so they're going to have chronic respiratory symptoms. They have to do breathing treatments, and so their lungs have to work harder, so they have much higher calorie needs. They have pancreatic insufficiency, so the ducts in the pancreas can get blocked, so that's going to affect the release of some of the enzymes that the pancreas releases, the amylase, lipase, proteases, so they're going to have fat malabsorption issues. They're going to have growth issues. CF-related diabetes, about 10 to 15% of adults with CF have diabetes, and we're not exactly sure the cause of that other than, well, it's blocking the ducts in the pancreas, it's causing the pancreas to be inflamed. That could be causing the pancreas to not produce and release insulin like it normally would. So you do see a little bit more diabetes with the CF patients. You might see cirrhosis if some of those ducts in the liver get blocked, and that can cause portal hypertension. Dehydration can happen because CF patients have a much higher concentration of sodium and chloride in their sweat, and they also tend to sweat more. So they're going to lose a lot of sodium and chloride, so that can cause dehydration and electrolyte imbalances. So a lot of nutritional implications with CF. And usually there's dietitians that specialize in CF, and this is all the only type of patient they see, or just CF patients, outpatient and inpatient. Some of the nutrition issues, it's really related to that previous slide, all that physiology. So poor digestion and absorption of fats and fat-soluble vitamins because the enzymes aren't being able to be released by the pancreas because the ducts are blocked. Malnutrition and abnormal growth, failure to thrive. So when we start to see an infant that's got failure to thrive and they're falling off the growth chart, a lot of times they'll right away do some tests and see if they have CF and rule that out. Chronic use of steroids. These patients are usually on long-term steroids, and we know that the drug-nutrient interactions with steroids, so they're going to need a calcium supplement. Nutrition interventions, they may receive PERT, which is pancreatic enzyme replacement therapy, so they're going to get pancreatic enzymes with their meals and snacks to help break down the fat and help with digestion and absorption. Their energy needs are a lot higher, maybe up to 200% higher than the RDA for their age. So they need a lot of calories. They need more fat. They need at least 35 to 45% of their total calories from fat because they're not absorbing most of the fat, so they need more to try to absorb it. MCTs are a good source of fat because then they don't need the lipase to break it down in the bile. Fat-soluble vitamins, they'll be on what they call an ADEC supplement because they're likely to malabsorb fat-soluble vitamins, so they need a supplement, and that can be liquid, chewable, or a pill. Because they're losing so much sodium in their sweat, they need a high-salt diet. So they need all of these foods that we tell most people to stay away from. They need high-fat, high-calorie, and high-salt foods every day. Yeah, so, and likely then they still might not meet their needs. So a lot of times they're going to be on some type of high-calorie supplement, like a Ensure Plus or Boost Plus or milkshake or something to get extra calories in. And then they may even need a PEG tube to get overnight feedings because they just can't get enough calories in during the day. So these patients are usually going to be really, underweight on your growth chart. They're going to be, in the lower percentiles. Okay, BPD, which is bronchopulmonary dysplasia, is another respiratory condition usually seen with premature infants. So it's characterized by pulmonary inflammation, and then you're going to see impaired growth and development of the lungs, and that's due to incomplete recovery from some type of lung injury, probably associated with being born prematurely. So those lungs can't synthesize that surfactant fluid. Sometimes it's also called chronic lung disease of prematurity, so you might see that CLD. Risk factors as far as a cause for BPD, prematurity, a perinatal infection, something called meconium aspiration. Meconium is the very first stool of the infant, and if there's any type of fetal stress that occurs before birth, it can cause the infant to release that stool before birth into the amniotic fluid, and then they can breathe it in while they're still, before they're born. So that's going to lead to major respiratory problems if they inhale that. So that's meconium aspiration. The tracheoesophageal fistula, that's another risk factor for BPD. Probably the most common one being the prematurity and just the lungs not being developed. But they're going to have a lot of nutrition issues. A lot of times they're born right away, they need to be mechanically ventilated in order to breathe. So eventually, once they get off that ventilator, they're not going to have the swallowing function developed. They're going to have an aversion to anything coming at their mouth, so they don't want a bottle or they don't want food. They have this aversion that develops from having that tube down their throat. The tube being down their throat long term can cause reflux esophagitis. And then because they have such issues with breathing, with breathing, they're gonna get tired when they're eating. So, it's hard sometimes to breathe and eat. If you have a cold and your nose is stuffed up and you're trying to eat, sometimes it's hard. So they're gonna often have growth failure because maybe they're not taking in enough. They have much higher requirements, hypoxemia, delayed bone mineralization and osteopenia can happen. They're gonna have increased energy needs because of that increased work of breathing. They're gonna have an increased RMR, they're gonna need more energy for tissue repair, and they're gonna need catch-up growth. You're gonna have to calculate catch-up growth for these patients. And typically they're gonna be on long-term steroids too, so think about those drug-nutrient interactions. So for energy, it's usually 25 to 50% higher than their age-matched controls, and maybe up to 130 calories per kilogram, maybe even higher. For protein, just, if they're premature, they've got immature kidneys, so just, watch their labs closely. They can't handle too high of a protein, but maybe up to 4 grams per kilogram, which should be about 8 to 12% of their total calories. And then for carbohydrate, remember, too much carbohydrate increases the respiratory quotient, so we don't want to do that with these patients. So you don't want to do excessive carbohydrates. So if you're trying to add some additives to bump up their calories in the formula, you might not want to do carbohydrate with this population, maybe a fat or a protein. And so interventions on early aggressive nutrition support, try to get them transition to bolus feeds. If breast milk is an option, breast milk with human milk fortifiers preferred. Studies show that it helps to reduce sepsis and the neck. If they're premature, they're going to be on a special premature formula with higher calories. We have studies that have demonstrated that vitamin A supplementation used in low birth weight infants has led to decreased incidence of BPD, decreased days on the ventilator, and then decreased number of days in the ICU. And infants are born, or preemies are born with a very small supply of vitamin A, and you need vitamin A for lung development. So these patients need a vitamin A supplement. Iron's important, which would be in the formula. We're going to closely watch their electrolytes and fluid status. They may actually need a fluid restriction if they've got BPD. Also maybe a sodium restriction. And making sure they're getting enough minerals so they don't get the osteoporosis, osteopenia. And then if they're on a higher calorie formula, then we need to make sure that the caregiver knows how to make the formula and they get the recipe and all that. Okay, and then the last section is some of the developmental disabilities. These are more conditions, not disease states. Okay, so developmental disability is defined as a severe chronic disability that's attributed to a mental or physical impairment. It could be a combination of both. Usually manifests before 22 years of age, and then it's going to continue indefinitely. So it's going to result in substantial functional limitations in 3 or more areas of major life activity. Usually there's a need for generic or specialized interdisciplinary care treatments, other services for an extended period of time, sometimes lifelong. So developmental disabilities are often caused by fetal abnormalities, birth defects, and then there's some metabolic disorders we'll talk about, genetic disorders. Okay, so these are the ones I'm going to mention again briefly, just kind of what they are and what are the nutritional implications, just because I think these are the ones that you'll see more frequently, so they're more common, I guess. Down syndrome, Prader-Willi, spina bifida, cerebral palsy, cleft lip and cleft palate, which is a birth defect, fetal alcohol syndrome, autism, the autism spectrum disorders, ADHD, and then some of those genetic inborn errors of metabolism. I'm just going to mention a few of those. But in general, nutrition issues with some of these disabilities, you might see growth retardation. You also might see obesity. You might see failure to thrive. They may have problems feeding, metabolic disorders, drug-nutrient interactions, constipation, renal problems, and then with this population, it can be really difficult to get their height and weight measurements accurately. Sometimes they're confined to a wheelchair, so you might have to weigh them in their wheelchair, deduct the weight of the wheelchair. Also, they may be contracted, so you might not be able, they can't stand up sometimes to get a height, so you might have to measure their arm span or measure them segmentally, the ankle-knee ratio. So sometimes that can be a little challenging, not impossible, but just a little challenging. So the first one that I'll talk about is Down syndrome. This is a congenital defect. It's characterized by a presence of an extra chromosome in each cell. So normally we have 46 chromosomes. These patients have 47 chromosomes in each cell, so they have one extra chromosome. And that abnormality occurs with chromosome number 21. So they have 3 number 21 chromosomes instead of 2. So that's why it's called trisomy 21 sometimes. Nutrition issues with Down syndrome, they do tend to have a higher rate of obesity. There are some special growth charts for Down syndrome, but most of the research I've read says that you can plot them on regular growth charts as well. They may have difficulty coordinating sucking, swallowing, and breathing. They may have constipation because they have low overall tone. And they may have issues weaning, self-feeding, eating solid foods. Physically, they may have what's called mid-facial hypoplasia, which is where the middle part of their face develops more slowly than the outer part of their face. So that can affect, how they can suck and swallow and breathe and eat. Also, they may have a smaller oral cavity, a smaller mandible or jaw, nasal congestion. All of these things can affect how they're eating and breathing. Abnormal dentition is common, smaller hands and shorter fingers. We want to try to prevent obesity or treat obesity. They tend to be not as physically active, and that's because they have low overall muscle tone. So we want to try to get them into some physical activity that they can tolerate. So more physical activity, the better. Assist with any feeding problems, avoid overfeeding. And then because of that low overall tone and the decreased physical activity, they're at risk for constipation, so make sure they get enough fluid and fiber to avoid that constipation. Okay, Prader-Willi syndrome. This is another genetic disorder, so it's caused by DNA abnormalities of chromosome number 15. But it's different than Down syndrome in that there's not an extra chromosome. There's actually part of chromosome number 15 is actually missing. So it's also characterized by hypotonia, also hypogonadism, some developmental disabilities, small hands and feet. They do have some atypical facial features, and they can be obese because the main characteristic they have is that insatiable appetite. So they're constantly hungry. And that's thought to be related to, they release more of the hormone ghrelin, which tells us that we're hungry. So they're releasing more of that, so they're just constantly hungry. And usually it's identified in early childhood, somewhere around the age of 1 to 4. Nutrition issues, they're unable to control their food intake because they're constantly hungry. So they often will sneak food or steal food. They have decreased muscle tone. They have that hypotonia, low lean body mass, and then increased body fat and obesity, lower activity levels, and then a lower metabolic rate also. They also have growth hormone deficiency, and that's why one of the interventions is growth hormone. Also, we want to increase their physical activity, secure food. So we have to lock kitchen cabinets and refrigerators and secure food because they're constantly hungry. Support groups might be beneficial, and then you're going to monitor their weight and height and intake closely. Spina bifida is also a birth defect. It affects the spine and the brain. It's caused by a neural tube defect that occurs during that 3rd and 4th week of pregnancy. Symptoms can range from lower extremity weakness to total complete paralysis and total loss of sensation. So this is another one that can be mild and that can also be very severe. Nutrition issues, they usually have a shorter stature and a limited mobility. Sometimes they're in wheelchairs, so they're going to have lower energy needs. Obesity is common. It can be difficult to get an accurate height and weight. A lot of times they're not able to ambulate or stand up, they're contracted. So you might have to do some segmental type heights, or if you can, an arm span. They sometimes are picky eaters. They're at high risk for pressure ulcers because a lot of times they are non-ambulatory and they might be wheelchair bound, so they're at risk for pressure ulcers, also UTIs and constipation just because of that limited mobility. Swallowing difficulty if it's affected the brain, so that's common. As far as preventing spina bifida, we know folic acid is key in that. So preconception folic acid can help prevent, and about 50 to 70% of the cases can be prevented by that preconceptual folic acid. Adequate fluids and fiber to help with the constipation issues, helping with feeding problems if they have swallowing issues or they can't feed themselves. And some of these patients may require enteral nutrition if they've got swallowing difficulty. Okay, and then cerebral palsy or CP. When you are dealing with the pediatric population, CP usually means cerebral palsy. But when you're dealing with an adult population, be careful because it can be confusing. CP means chest pain. So the definition for CP is brain damage to the motor centers in the brain, and it can happen before, during, or after birth. It's characterized by non-progressive, so it doesn't continue to progress and get worse, physical and mental disabilities. And this is another one. It can be very mild. You can have someone with very mild CP and they might not have really any issues. And it can be very severe to someone that's on a feeding tube and wheelchair bound. So it can range. They may have feeding problems, growth failure, wasting of muscle. Might be difficult to get a height and length on these patients too. Again, if they're wheelchair bound, you might have to do arm span. Constipation because of that lack of mobility, drug-nutrient interactions. Reflux is common with these patients. Swallowing difficulties, and then they're at risk for pressure ulcers as well if they're non-ambulatory. Nutrition interventions, getting enough fluid and fiber again. If they've got a lot of emesis or reflux, they might need an antiemetic. They might need a softer or pureed diet, thickened liquids if they've got swallowing issues, assistance with feeding, adaptive equipment, and sometimes in severe cases they can't eat by mouth at all, and they need a feeding tube to meet their nutrition needs, so they might require enteral nutrition. Okay, so this table was put together and just shows those last 4 developmental disabilities and their calorie needs, because it can be really tricky assessing calorie needs for these patients, especially, again, they can range from mild to severe, and so it is tricky. But you base it off of their height. So, for instance, Down syndrome for girls, 14.3 calories per centimeter. So that's a good starting point. That's what I would use this for, as a starting point, and then just keep track, plot them on the growth chart, see how that's working for them. Might need to be adjusted. Spina bifida is the lowest as far as calorie needs, so it's only 9 to 11 calories per centimeter to maintain weight, and then if they're trying to lose weight, 7 calories per centimeter. If they're trying to gain weight, I'd probably go up to 13. So that's just a guideline for those. And protein needs would be just the DRI for their age. Cleft lip and cleft palate, this is a birth defect. So it results from incomplete merging and fusion of the embryonic processes during formation of the face. So here's your cleft lip. This is a partial cleft lip. This is a complete cleft lip. Cleft palate on the right down there. So you have a cleft palate. This is just affecting the soft palate. This is going from the soft all the way to the hard palate. So as you can imagine, looking at those images, they're going to have some issues with feeding from a nipple, or breastfeeding, or sucking, or swallowing. Cleft lip and cleft palate are repaired surgically, sometimes in stages of surgeries. They have to have several surgeries before it's completely repaired, and it can be, totally repaired, and you can never even tell they had any issue. So if the mom wants to breastfeed with these patients, you might just need to have the mom pump, and then sometimes they can use a specialized nipple or a special bottle to feed. So they could certainly still receive breast milk. Their needs are normal. They don't usually have higher energy needs or protein needs, but they tend to take in less volume just because they have feeding difficulties. So you might need to concentrate the formula and make it higher calorie per ounce because they're just not as likely to take in the volume that they need. So they may need enteral nutrition depending on how severe, and then you're gonna eventually, transition to solid foods and just feed slowly. They might need more time with eating. Fetal alcohol syndrome. This occurs when a woman consumes alcohol during pregnancy, and this can cause mental and physical defects to the fetus. The criteria, this is what's actually used to diagnose fetal alcohol syndrome, a growth deficiency. So you're going to see a growth deficiency on the growth chart. They have certain facial features like thinner upper lip, smaller eyes associated with fetal alcohol syndrome. They're going to have some central nervous system damage, and then that prenatal alcohol exposure. So those are the criteria for diagnosing fetal alcohol syndrome. So their height and weight might be below that third percentile in the growth charts. They may have failure to thrive. Feeding problems are common because of that central nervous system damage. So they might have a weak suck ability. They might have oral motor skill problems. Their energy and nutrient needs are typically going to be the same as a non-affected child, but they might need more if they have failure to thrive. So you just kind of have to assess that. Okay, autism. So the autism spectrum disorders, or ASD. These are defined as neurologic disorders that usually appear by the age of 3. And they're diagnosed by seeing an impaired social interaction in the child, impaired communication skills, and then they're also going to have restricted, repetitive, and stereotypical interests and behaviors. It's 4 times more common in boys than girls, and at this time we don't know the cause of autism. Usually their growth is normal. They don't have any special nutrient needs for the autism spectrum disorders. But they do usually eat a very limited variety of foods. They tend to be very picky eaters. So that's going to cause maybe an issue with getting in enough vitamins and minerals. So they may have some sensory issues or issues with certain textures. So they may also fixate on a certain food. So I had a patient with autism, and all he would eat was plain potato chips. So breakfast, lunch, and dinner was plain potato chips. Something about that was the texture he liked, and that was all he would eat. So they can be very challenging trying to get them to get their vitamins and minerals and all of their nutrient needs met. Just read an article in the brand new journal that just came out this past month. I just got it in the mail a few days ago, and there was an article in there on autism. And it showed that children with autism consume more energy-dense, nutrient-poor foods, fewer fruits and vegetables, and more sugar-sweetened beverages. So that's an article. They tend to be more, they called it food selectivity. So they're more picky eaters or selective with their food choices. That was in the Journal of the Academy of Nutrition and Dietetics. For interventions for autism, Really, it's just trying to get them to eat a good variety of food, a good well-balanced diet. It can be challenging, but that's really the main thing that you want to focus on. There's some indication, and by indication I mean these are theories, that children with autism could benefit from omega-3s, antioxidants, minerals, a mercury-free diet, or an allergy elimination diet. So again, theories. Some patients with autism do show antibodies to casein, gluten, or soy, which just indicates that they have an allergy to those. So there's an indication that those might be more common with patients that have autism. So research as far as autism is ongoing. Again, these are theories, these are anecdotes. There just hasn't been any studies that have been done in this population, any good studies, any of the double-blind, randomized, placebo-controlled studies. So nutritionally, just a well-balanced, good variety for a diet. ADHD, attention deficit hyperactivity disorder. So a child with ADHD has significant issues with attention, hyperactivity, and acting impulsively. And that can affect the child at home, at school, and then also social situations. Really, there aren't a lot of nutrition issues, depending on what their behaviors are, but the main one is the drug-nutrient interaction. So a lot of these kids are prescribed a medication such as Ritalin. Ritalin affects appetite. It can actually decrease appetite, so then you might see some weight loss with that patient. So it's really you got to look at what medications they're on and how that's affecting them. As far as nutrition intervention, again, just a regular, wholesome, healthful, well-balanced diet, maybe limiting distractions as much as possible at meal times. Again, some theories or anecdotes, so maybe this worked for somebody, but we don't have any good studies showing anything really relevant. But possibly they're looking at the food dyes and the food colors with ADHD, avoiding caffeine and sugar, and we know those could contribute to making someone more hyperactive. That makes sense. Mega vitamins, mega doses of vitamin, and then the essential fats. So getting those essential fats might help. So again, we don't have any the double-blind, placebo-controlled, randomized studies, but those are just some theories. Okay, and then the last couple slides, I just want to briefly mention some of the inborn errors of metabolism. And again, there are hundreds of these, over 200 different genetic metabolic disorders, and they're very, very rare, but I'm going to mention 3 of the more common ones. So with these disorders, what happens is there's a defect in the activity of a certain enzyme, and that enzyme is needed to catalyze the synthesis of a certain substrate. This can result in accumulation of compounds with harmful effects. So the enzyme's needed to break down the substrate, but we don't have the enzyme, so now we're going to have buildup of that substrate, and that can be toxic, harmful. And then we need that enzyme to break down that substrate into other substrates. Now we're going to have a deficiency in those substrates that we need. So because of that enzyme deficiency, that you can have a lot of nutritional issues. So there's over 200. Most of them are autosomal recessive. We do screening at birth for every state is different. So every state has their own list of mandatory neonatal screenings for these disorders. PKU, for one, is mandatory to be screened in every state, but it just varies from state to state as to what disorders they're going to screen for. And they just do a quick little heel prick blood test and screen for these disorders at birth. Nutrition issues, it's going to affect their central nervous system. They're going to have poor growth because they're not going to tolerate the formula or breast milk. Failure to thrive, developmental delays, neurological deficits that can be specific to the disorder. So as soon as we find out what disorder they have, we need to restrict whatever that offending metabolite is. So if it's PKU and they can't break down phenylalanine, we need to restrict phenylalanine. So as soon as we can diagnose them, we need to figure out what that offending metabolite is and eliminate that from their diet. They need to still get enough calories and protein. They might need parenteral or enteral nutrition. There are hundreds of metabolic formulas designed for this population, and usually they're very important and necessary. So for your PKU, they would make a formula that doesn't contain the phenylalanine. And then diet education, you know, again with PKU, just using that as an example, phenylalanine is in almost every food that has protein. So educating them on all the foods that they can eat that are very low in protein, and counseling for the family and the patient. Okay, so these are three of the more common ones, and again, these are all very rare, but these are probably three of the more common ones. PKU, phenylketonuria. So this is when there's a defect in the phenylalanine hydroxylase enzyme. So that causes an inability in the body to convert phenylalanine to tyrosine. So we can't break down phenylalanine, so that builds up and becomes toxic. And we then have a deficiency in tyrosine because we're not breaking down the phenylalanine to tyrosine. So the formula for these patients, it's going to be a metabolic formula. It's not going to contain phenylalanine, and it's going to contain tyrosine. Okay. So phenylalanine must be limited in the diet, which again, it's in a lot of foods, pretty much everything that has protein. Okay. Usually they say, don't eat any foods that have more than 1 gram of protein per serving. So they have to be on a phenylalanine-free diet, and then on that formula. The formula is key just because it's going to help them get enough protein and calories because they're on such a restricted diet. And phenylketonuria is one of them that is screened in all 50 states, so it's probably the most common one. Maple syrup urine disease. So this involves a defect in the activity of alpha ketoacid dehydrogenase enzyme complex. So that prevents the metabolism of the branched chain amino acids. So leucine, isoleucine, valine. Particularly, there seems to be more of a problem with the leucine than the other two. So the branched chains can build up and they can become toxic to the brain and other organs. So they're going to need a diet low in the branched chain amino acids, which again, that's difficult because those are in most foods with protein. So they're going to be on one of those metabolic formulas also. That's going to be, that's not going to have the branched chain amino acids. And then galactosemia, that's the third one. And that one also is mandatory to be screened for in all 50 states. So that involves an enzyme defect in galactose metabolism. So they basically can't break down galactose. They need to eliminate galactose in their diet. And that can cause failure to thrive, hepatomegaly, and it can cause life-threatening sepsis in the newborn if they have that buildup of galactose. Exclusion of galactose and lactose from the diet for galactosemia. All right, that's it.